updates in the fertility research. So I added small uterus as we asked to restrict to the theme of the slides, but I had small uterus for the gynae. So I don't have any conflict of interest. In this presentation, we discussed about the infertility and its global burden, review the pathophysiology and systematic association relevant to the internal medicine, summarize advances in diagnostic, assisted reproductive technique and medical management, will highlight the surgical approach and outcomes, will discuss finally the ethical and future direction. As we know, the prevalence of the infertility around worldwide 15% of the couples. Internal medicine relevant, we have a contribution of diabetes, obesity, thyroid dysfunction, and autoimmune diseases. Environmental iatrogenic contributors like chemotherapy, radiotherapy, and toxins. Pathophysiology, we have the ovarian reserve declines with the marker anti-mullerian hormone declines and antral follicular count, oocyte quality. In the male infertility mechanism, the DNA fragmentation, oxidative stress, the endocrine metabolic interplay like PCOS and insulin resistant. The genetic predisposition, we have BRCA1 and 2, the chromosomes deletions. We have the diagnostic updates, we have the AMN standardization and improved predictive value. We have the advanced semen testing like DNA fragmentation, proteomics, and AI sperm selection. The uterine tubal imaging, 3D ultrasound, stereosalpingo contrast sonography, and we have the genomic panels for the recurrent pregnancy loss. And for the medical advanced infertility, we'll speak about two topics: the immunotherapy trials for recurrent implantation failure, RIS, and role of metformin and acetols in the PCOS. As we know, the immunotherapy studies like we have the IVIG, intralipids, and tacrolimus steroids. We have small evidence of heterogeneous small RCTs and cohort, and meta-analysis shows mixed results. The European Society of Human Reproductive and Embryology showed that investigate the causes first, and then avoid routine empirical immunotherapy, consider only for selected patients or within trials. The candidate selection should be documented immune abnormalities after failure of standard optimization and full informed consent. And we should monitor for the safety of these treatments like infusion reaction in the IVIG and intralipids and immunosuppression risk for tacrolimus, and we should consider the high cost of this kind of treatment. So this study for the IVG and recurrent IVIG in the recurrent implantation failure 2024, it's combined 12 studies. Number of cases is 1,023 IVIG versus 2,276 controls. The results show that increase in the clinical pregnancy with the odd ratio 5.1, increase in live birth rate with the odd ratio of 4.6, and increase implantation rate with OR 2.3, and decrease miscarriage rate with OR 0.6. So the study conclude that the IVIG shows significant improvement in pregnancy and live birth outcome in the repeated implantation failure, best for selected patient, unexplained RIF or immunological factor, good embryo quality, but this study have limitation like the heterogeneous studies and variable dosing and high cost. So it's not yet recommended. Second, we'll discuss about metformin and acetols in the PCOS. The polycystic ovarian syndrome affects around 6 to 12% of reproductive age women. It's characterized by anovulation, hyperandrogenism, insulin resistance, and metabolic dysfunction. The targeted therapies we have addressed both reproductive and metabolic consequences. The mechanism of action of metformin in the PCOS, we have improved insulin sensitivity like hepatic and peripheral, reduce hepatic glucose production, indirectly decrease the ovarian androgen synthesis by lowering insulin levels, and may restore the menstrual cyclicity and ovulation. The current guidelines, like ISHRO guidelines, not first line for the ovulation induction. We use first letrozole, and can be used for metabolic indication like impaired glucose tolerance and type 2 diabetes mellitus risk, and may be considered in women with BMI above 25 and metabolic risk factors. The clinical evidence showed that effective in improving menstrual regularity and ovulation rate, but less effective than clomiphene or letrozole for live birth outcomes, improve the metabolic outcomes, decrease fasting glucose, and decrease triglyceride, and maybe reduce the risk of type 2 diabetes in obese PCOS women, as monotherapy weight reduction is modest, but combined with the lifestyle modification. This study that shows the metformin with gonadotropin in PCOS, meta-analysis combined 7 RCTs, 1,023 cycles. The population was women with a PCOS undergoing ovulation induction, and the intervention was metformin plus gonadotropin versus gonadotropin alone. The key outcomes was it showed that increased live birth with the OR around 1.9%, and the pregnancy rate increased by with the odd ratio 2.2%, and cycle cancellation with the odd ratio 0.4%. The limitation of the study, that study quality was with low moderate, and the variable secondary outcomes. So the clinical implications showed that metformin improved live birth pregnancy outcomes in PCOS patients on gonadotropins with the fewer cycle cancellation. Now we'll speak about the incitos in PCOS. We have two types of incitos, the myoincitos and dichorioincitos. It's considered like insulin sensitizing agents, act as a second messenger in the insulin signaling. The myoincitos improve the FSH, follicular-stimulating hormone signaling, and oocyte quality. The dichorioincitos modulate the insulin-mediated androgen production in the ovary. So the myoincitos supplementation for the patient with the PCOS will improve the menstrual cyclicity, will enhance the ovulation and spontaneous pregnancy rate, will improve the oocyte and embryo quality in the IVF cycles, and it's safe and well tolerated by most of the patients. The dichorioincitos may help in hyperandrogenism, but high doses risk worsening the oocyte quality resistant with the fewer GI side effects. The clinical evidence, we will combine the myoincitos and with dichorioincitos, 40:1 ratio, reflects physiological plasma ratio and shows best result in improving the insulin sensitivity and ovulatory function. The meta-analysis showed that benefit of myoincitos with dichorioincitos in restoring the ovulation and improving metabolic profile, comparable to the metformin improving insulin. So as I am surgeon, I will speak about surgery for the infertility. So the surgical intervention in fertility, we do like hysteroscopy, surgical polypectomy and myomectomy adhesolysis, laparoscopy for endometriosis resection, tuboplasty, ovarian drilling, and then now we're doing the robotic surgery as well, oncofertility surgery for ovarian tissue cryopreservation and ovarian transposition. So for the ovarian rejuvenation medicine, in the morning I know that you have the regenerative medicine. As we know that the 10 to 15% of couples worldwide affected with the infertility, because of the poor ovarian response or premature ovarian insufficiency, remain the major challenges. We have limited option, but this option is not available in UAE, like oocyte donation versus experimental therapies. And then we have the alternatives like regenerative strategies, the PRP injection and stem cell therapy. So I speak about PRP. The PRP is a plasma-rich, platelet-rich plasma. Is a blood product enriched in the growth factors and cytokines, which promote tissue regeneration, angiogenesis, and immune modulation. The PRP regeneration potential relies not only in their plasticity, but also in the secretion of trophic factors and modulation of the local immune response. So usually I'm doing it in the aseptic condition during another procedure for myomectomy or laparoscopy or stereoscopy in the operation theater under general anesthesia or regional anesthesia. So we extracted 2 tubes of venous blood, and then as you can see in this photo, and then we centrifugated in this machine 3,500 turns around 15 minutes to extract the PRP. So the PRP, we have like 3 components. We will have the places poor plasma, places rich plasma, and red blood cells. So we take the first 2 layers, and we inject it intravaginally or laparoscopic, depending on the method of the surgery I'm doing. So it promotes the angiogenesis and increase the fecogenesis. So this is how we inject it during the surgery, and then the mechanism of action of PRP is generated interest. The PRP therapy has generated interest for its regenerative properties, and platelets will release the growth factors that stimulate cell proliferation and tissue regeneration, promote the restoration of the normal tissue architecture, potentially reduce the risk of scarring and fibrosis. Also, its anti-inflammatory properties maybe contribute to alleviating the chronic inflammation. Actually, it's not a new technique, because before we used ovarian drilling by using like the monopolar, and we do like small holes in the ovaries to stimulate the regeneration. But now we added this PRP which is proven with a study to have improve the quality of the PRP, of the ovary. So we'll discuss about the clinical evidence. The PRP in the ovarian regeneration, we have meta-analysis of 38 studies, 2,256 women with diminished ovarian reserves showed the significant improvement in the AMH, the anti-mullerian hormone, increased of 0.2 in the first month to 0.26 in the second month. In the third month, we have 0.36. And the SSH would decrease from 10 to 7 and to 8 over the respective months, 1, 2, 3. And then the antral follicular hormone, antral follicular count also means the increase of 1.6. The oocytes retrieved increased by 0.81. The embryos created increased by 0.91. Spontaneous pregnancy 7%, IVF pregnancy 18%, live birth is 11%. Another study with specific cohort study, 510 women with a poor ovarian response, mean age was 40, showed that the AMH increased from 0.35 to 0.53. The AFC or antifollicular count from 2.6 to 4.2. The pregnancy outcome, spontaneous pregnancy is 4.3. IVF pregnancy 17.5, live birth 11.4. So the future direction and ethical issue that we have now, the artificial intelligence in the embryo and sperm selection. We have the uterus transplantation with the first birth reported. Mitochondrial replacement therapy, ethical challenges we have like the access and the cost and gene addition. So the take-home message, we have the infertility is a multi-systemic condition relevant to the internal medicine and surgery. That's why I thank you for invitation for this conference. The assisted reproductive technique and regenerative therapies are advancing but requiring caution. Surgery remains essential for the selected patient, like endometriosis, tubal factors, male infertility, and multidisciplinary collaboration is the best outcome. Thank you, and I think I'm in the time.